Hello, today we shall discuss about history taking in Obs Gyn. I've divided this into a number of sections so that it's easy for you to understand. The first section is going to talk about patient's identification details. And in this, we're looking at the name of the patient and the age of the patient. The sex, normally in Obs Gyn, we receive mostly female, but occasionally you may also see one or two male patients who come to your ward. So it's important to put the age, the sex there. The occupation, sometimes this relates to the kind of problem related to what someone do, the tribe, educational levels, religious affiliation. These are very key. The tribe will tell us about the cultures that people do. You know, certain things, there are certain communication that is not allowed in a particular culture, or certain kind of things are not allowed in a particular culture. So before you actually work on someone, it's important to know what is their tribe and then their educational levels that will help you on the depth of information that you need to use. Sometimes the common language used for communication is English, but in certain cases, it would be hard to communicate someone in English. Religious affiliation, religion like Jehovah's Witness, you know that they actually don't accept blood transfusion. So it's important to have that at the back of your mind. Certain religions that does not allow you to use contraceptions, family planning, especially the modern family planning methods. So it's important to look at that. If they're married or not, the next of kin will actually be the primary contact if anything happens, or if someone needs to be contacted. The next of kin is very key. The nearest health center should be noted so that in case of follow-up, and if you do not need them to travel a long way, probably they can be seen in the nearest health center. The gravidity and the parity should be noted. The last normal menstrual period, the gestational age at that time, and the expected date of delivery. Normally, calculate the expected date of delivery and the gestational age. The expected date of delivery and then the gestational age you calculate from your last normal menstrual period. Date of admission and date when you actually clocking the patient may need to be noted. The present complaint or the chief complaint or the presenting complaint should be noted, and this should be in a chronological order. The ones that are occurred first should appear first, and then the one that occurred last should appear last. And this chief complaint can be in any form. Someone can come with abdominal pain, vaginal bleeding, loss of fetal movements or reduced fetal movements. They may actually be leaking liquor per vagina. They could also have swelling in the lower limbs, and then dizziness or loss of consciousness. Any other complaints that they come with can actually be a presenting complaint. Sometimes a presenting complaint is just a referral. Probably they were referred from somewhere that they should come in. That should also be a presenting complaint. Or it can be a postoperative patient. You just look at the complaint that they have after the operation. That should be the present complaint. The history of presenting complaints should be exhausted fully and should be done in a systematic way so that you get it into details. And this is very important. The details will lead you to a diagnosis and also help you to tease out the differential diagnosis that might be there. If a particular system is affected in the present complaint, it should be reviewed in the history of present complaint. So that should be noted very well. The other thing that should be done is review of other systems. In this, you look at the systems that has been not reviewed in the history of present complaint, but there may be some complaint that is hidden there. So it would be good to review all the systems. And then look at the present obstetric history. This present obstetric history and past obstetric history should come first before past gyn history if the patient is an obstetric patient. If it is a gyn patient, you first review past gyn history before you review these other details later. In the present obstetric history, you may actually need to repeat the gestational age at that point, and then the last normal menstrual period. And if she has done an earlier scan, you should also report the gestational age according to the sonographic findings, especially if they have done it in the first 14 weeks of the pregnancy. That should actually give a very accurate dating of the pregnancy. And also, if there is any other findings that was seen in the scan, should be noted there. Maybe it's having a twin, and if it is a twin, is it a dichorionic, diamniotic twin pregnancy? If there is a problem, maybe she has had bleeding, something like that, it should be noted at this point. The gestational age at booking visit should be noted as well. At the moment, Ministry of Health is advocating for having a booking visit as soon as you miss your period. And this is very key here. And then how many times has she attended antenatal until the time you've actually clocked her? If there's any issue of booking blood pressure, should be noted. If there are any complication that has arisen in this pregnancy, maybe she had malaria, bleeding, pelvic pains, admissions, maybe she had excessive vomiting during the pregnancy, should be noted at this point. The past obstetric history should look at the maternal complications that occurred in the previous pregnancy. Maybe she had bleeding, hypertension, postpartum complication, including bleeding, and maybe postpartum psychosis. Normally, it's very key to look at the psychiatric history at this point, because that may actually repeat itself. If a mother has postpartum blues, it should be noted at this point. The newborn weight should tell us a lot. This would tell us risk of maybe getting a mother having gestational diabetes or fetal growth disorder if they're small, if they have maybe risk getting shoulder dystocia if they had macrosomia or cephalopelvic disproportion. This should be noted at the post-obstetric history. Then newborn's gender, this will actually help to look at the expectations of the family. Sometimes if a mother has had many boys, they probably is expecting a girl, so the expectations should be noted at this point. Fetal and neonatal complication, probably if they had an early neonatal complication, admissions, why were the babies admitted, if there was a death, if there was any evidence around the death, it should be noted at this point. History of past gyn history, of course, the gyn procedures, especially if they have had exploratory lab, manual vacuum aspiration, dilatation, curettage, or myomectomy, or any other obstetric procedures that has been done, ectopic surgeries, it should be noted in the past obstetric history. Also part of the, past gyn history. Also part of the past gyn history, you look at the menstrual history, the age at menarche, how regular is the period, the days she spends bleeding, and then the cycle length, the pains that she has during the period, any concern about the flows, is it too much, is it too little? If there is any intermenstrual bleeding between the periods, it should be noted at this point. History of contraception is key. You need to know knowledge of the patient about the contraception method. You also need to look at if they have ever used any of the modern contraceptive methods, any beliefs that they have about it, if they have side effects, if currently they are using it, or if they discontinue, probably why did they discontinue? Is it because of side effects? Is it because of domestic violence telling them to stop using that, or is it because they want to get pregnant? It should be noted at this point. Sex history, the age at coitus, and then pains if they have dyspareunia, number of partners they have ever had, and then the active partners they have at this time. Of course, this history may not be got completely clear because many people find it's private. If there is any concern about fertilities, should be noted, and this should be asked. It should not wait. Many people come with infertility issues, they don't tell you, they just present with another complaint. So it would be good to ask them what they think about that. The past surgical history should be noted if there is any history of surgery, especially involving the abdomen and the pelvis, because that will actually concern more of the Obs Gyn issues. And then burns, especially involving the perineum, and then any history of blood transfusion if they've ever had. Family and social history, look at the familial hereditary illnesses, maybe hypertension, that may actually result into a problem. Diabetes, you need to look at them. And then unexpected death in the family would be key. Familial cancer syndrome, especially if someone is aged and probably you're suspecting a cancer of the endometrium, the Lynn syndrome, you actually need to note it here if someone has ever had any family cancer syndrome history. Social support and livelihood is very key, especially to reduce the delays. The 3 delays model runs around this. And where they stay, probably what kind of housing they live in, if there's any risk of getting contamination of water, maybe they get malaria or something like that. It should be good to note that. And then at this time, you should come up with your diagnosis and the differential diagnosis. And this is purely from your history. So this should come out clearly. Should come out with the differential diagnosis. But of course, it's important to come with the pros and cons for the diagnosis. What is for the diagnosis and what is against a particular diagnosis, as well as for the differential. That should be listed clearly. At least you should come out with 5 differentials, 1 diagnosis and 5 differentials. That would be good enough for you. Sometimes it's hard to get that. Sometimes it's easy to get as many as even more than 5. After differential diagnosis, you should plan to do an examination. And an examination starts with a general examination. You do it from head to toe. It's normally good to do it head to toe. And then that should be in a systematic way so that you tease out all the possible things. But also, as you do this general examination, remember the present complaint and emphasize so much things that are in the present complaint that may actually affect the general appearance of the patient. It should come out clearly. And also, you need to think about doing an abdominal examination. An abdominal examination will start with inspection, and normally we'll demonstrate this in either our simulation lab or we demonstrate it at the bedsides. You need to look at the distension. That may also tell you about masses, if there are any scars, if there are any herniation, any unusual swelling, you should note that. And then in the palpation, you look at the guarding, the tenderness, and the masses. That should be, then also it's important to look at percussion. You percuss the abdomen, look at if there is any fluid trails or fluid. You may also need to auscultate, especially in a gynecological patient. You may actually, in the postoperative period, very important to know if the bowel functions have returned. The previous slides, these slides talked about a gyn in a gyn patient, but this one talks about abdominal examination in a patient who is an obstetric patient. You also, in the previous one, of course, it's important to ask for area area of tenderness. In the gyn, obstetric patient, you look at when you're looking at the patient, you assess the shape of the uterus, the shape of the abdomen. Of course, will tell you the shape of the uterus. If there's any asymmetry in the abdominal distension, if there are any fetal movement, you should be able to tell us if you have seen any fetal movement. And then if there are scars, look at the scars. And then the cutaneous signs of pregnancy, like the linear nigra there, you can see that there are also stria gravidarium there, and then any other superficial veins that are dilated, you should be able to note in your inspection. And then when you're palpating an abdomen, you may need to look at the uterine size. Of course, the fundal height is very important. You do that from the symphysis pubis to the fundus. You first need to locate the fundal the fundus, and then the extent of the fundus, and then you can actually do this. And this should be in centimeters. And then you can equate this into gestational age. It's very important to do that in centimeters, because the tape measure you're using is in centimeters, not in gestational age. There are some rules that applies there, and this is what you need to actually look at when you are doing that. You could also consider doing Leopold's maneuver, and these are actually 4 maneuvers. You look at the first maneuver, which is actually the fundal grip, and in this case you're actually trying to palpate at the fundus and try to determine which part of the fetus occupies the fundus. Is it the bridge? Is it the head? Or is it other parts of the fetus that occupies the fundus? The second maneuver is actually the lateral maneuver. You're trying to palpate and see on the sides of the abdomen which part of the fetus is there. Is it the back? Is it the back, or what exactly is there? And then in the third maneuver, you're looking at what they call the Paulick's grip. You actually use your dominant hand to feel and see what part of the fetus actually occupying the lower uterine segments. And then the fourth maneuver is called the pelvic grip, in which case you're trying to look at the position of the fetus. In a vertex presentation, you're trying to look at is it a right occiput, left occiput, anterior position. So that's what happens. Sometimes it's also important to note that this kind of examination can give you what they call the lie of the fetus. Of course, the lies of the fetus can be either longitudinal, it can be oblique, or it can be a transverse lie. And then a transverse lie, of course, that means that the long axis of the baby is actually in the longitudinal lie, the long axis of the baby is alongside the long axis of the mother. And then in the transverse lie, that is actually reverse of that. And then you also need to look at the presentation. Is it what part of the fetus actually occupying the lower uterine segments? That can be vertex presentation or cephalic presentation when the head is down, and in most cases it's vertex. It can also be breech presentation when the breech is actually the one which is down, or a shoulder presentation, or it can also be, in rare cases, you can actually have cord presentation or a compound presentation where more than one part is occupying the lower segments. You also may need to look at engagement, especially if you consider that the widest part of the presenting part has actually gone through the pelvic inlet. So we call that presentation. We call that engagement. And that's engagement is looked at when you look at the descent. Especially when the descent is more than 2/3, we actually consider that to have engaged patient. The fetus has already engaged. You may also need to do routine pelvic examination. You may need to do pelvic examination, not routinely, but it's important to consider doing pelvic examination. And there are conditions that allows you to, actually that's a requirement for you to do a pelvic examination. Like if someone has an offensive or excessive vaginal discharge, it's important for you to do a vaginal examination. If someone have a vaginal bleeding, if after excluding a previa, that's when you can actually consider doing this. If you want to do maybe screen the cervix, you want to confirm if the membrane has ruptured, if someone has a pain in the pelvis, it should be good to consider doing that. The contraindication would be in a previa, patient with previa, or if a bleeding, you're actually not sure what is causing the bleeding. we assume that probably that is a previous, so we don't allow you to do a digital pelvic examination, but you can do a speculum pelvic examination or a speculum vaginal examination. Also, in pre-labor rupture of membranes, it's important that you don't need to insert your fingers there, but you can actually do a sterile speculum examination to see what is really there. This is actually when you're using a speculum exam to look at the cervix. Of course, when you're doing pelvic examination, it's important to look at the genitalia. You need to comment about the skin of the genitalia. In most cases, you hear people say the vulva and vagina is normal. But sometimes there are conditions that are there, but you're not paid attention to. It's important that you actually look at them. And then you may also need to consider doing a bimanual examination. And in bimanual examination, one hand is actually in the abdomen, and then the other hand is in the pelvis through the vagina. And this will help you to assess properly if there is a mass, and if it is a mass, what is the mass involving, is it fixed or something like that, tenderness and whatnot. You can be able to get it through this. Thank you. Any question, we'll address it on the ward. Bye-bye.